today we'll continue from there. We saw some of those data banks, such as the those that are involved with the continuous data collection. The one we have for the routine health data, and as well as today we'll be looking at also some other aspects of disease data, such as that which we have for the integrated data surveillance, and also for data that has to do with Sentinel sites. That is, these are particular data that are actually very peculiar for some particular disease outcome. In case when we have disease outbreaks, how can we capture those data? How can we get those data? Those data are actually from Sentinel sites that have been set up over the years or over time to actually capture those diseases. For example, if Ebola should break out today, we have Sentinel sites that can actually capture that. And also, if we have cases of COVID-19, we also have Sentinel sites that can actually capture. We also have for Lassa fever, just as I mentioned yesterday, where we have sentinels somewhere in Ondo State, as well as in Edo State, where they can actually capture those kind of data. So today we'll continue. So yesterday we were able to see much about the routine health information system, actually capture continuous data which we have in our various health facilities. And before we go on to having the integrated disease surveillance system and response, I will just do a brief recap on the strengths of the routine health data, and particularly for the routine health data, we have they are ideally reflective and also integrated within the health system, which we saw yesterday. That all this data that we talk about when we talk about routine health data collection, they're actually integrated within the health system, such that those in the health system are those that are responsible for the collection of such data. And while those data are collected, they are being from the community level down to the local government level, to the state, and as well as to the national level. And all of this is also how the integrated disease surveillance system also work. They are also collected from the community level and down to the local government level, and as well to the state level, and then to the federal Ministry of Health. And that is the flow of disease. But however, we can also have situations, particularly when we are carrying out sentinel surveillance or surveillance within borders, across borders, that we have to investigate those people that are coming into the country. Particularly when we edge towards elimination for malaria, begin to see that surveillance will become very important for us, because we begin to track this disease as they come into border. We begin to track individuals that are coming into the border. And that is why anytime you want to travel, you always require a yellow card, which is yellow fever vaccine. All right? Because the country you are going into also want to track that, because that is a very contagious disease if it's actually been introduced in any country. And so, particularly, these sentinels are actually set up both at the border and also within the community level. If you take, for instance, most of the NTDs that are edging towards elimination, there are always traces within the community that we always want to track these diseases. Talk about onco, talk about LF, that lymphatic filariasis. Within the community level, we want to track that to actually see that as we are edging towards elimination, that any case that is being witnessed within the community is being tracked down, and then we administer appropriate treatment to them. And so, particularly the health facilities, they collect data on standard on standard integrated surveillance, on standard integrated disease surveillance and response system. And particularly, this is a strategy that is designed to improve the epidemiological surveillance and also to respond specifically to diseases in the country. So it's a fast response system that's been created. It's also integrated within the health system, so that any disease of interest that is being registered or that is being investigated upon, we track a very fast response to it, so that it doesn't spread within the community. And that is what modeling actually also helps to play, to also tell us how this disease can spread within the community. And that is, if we, maybe at the course of our lecture, we'll learn about the R0. All right, and I think Prof. 2 has mentioned that the R0 is actually the number of new infection that a single index case can actually transmit. And so this is what we also try to prevent in terms of surveillance in the country, so that we prevent the number of cases which a single individual can spread, and that is why we need to track at every point, whether at the borders or also at the community level. We want to track disease so that it doesn't spread across borders and also across even within this country too. It doesn't spread within the country across from one state to another or from one community to another. So surveillance system actually must be put in place at every level of health system, so that they're able to track diseases and we're able to prevent them we're able to nip it at the bud. All right. So also this flows from the health facility down to the local government. They're able to feedback to the local government on what is happening within the community. So they the local government receive forms from the health facilities, collate and also forward them to the state Ministry of Health. And from the state Ministry of Health, they can analyze and feedback to the front line, that is the health facilities within the community, and also feedback to the national level. And so they collect data, also forward to the Federal Ministry of Health, and then analyze this feedback and then back to the local government. And then from the State Ministry of Health, they also collect this data as well and feedback to the Federal Ministry of Health. And we are the divisions in epidemiology in the Federal Ministry of Health, which is also in collaboration with various donor agencies. Like we have various NGOs that are involved in this in various states of the Federation. And then, I think one question also came up yesterday, if donor agencies are responsible for sharing data. So donor agencies are not really responsible for sharing data. All they do is, one, provide the logistics which is required for any health outcome to be carried out within the state. So they provide the logistics. They also provide some of the funding too, if that particular disease is being funded. They also provide the funding too. But at the end of the day, it is on the onus of the Federal Ministry of Health and also the State Ministry of Health, and also, of course, the frontline health workers and also the CDCs that are also present within the community to collect this data and then feedback to each of these channels. And this data, if you, as modelers, want to access them, you also have to go to them, not through the NGOs or through the donor agencies. You still have to go back to the Federal Ministry of Health if it's domiciled within their preview, or you go to the NCDC to access this data. But you don't have to go through donor agencies to get this data, because once you publish your outcome and you cite any of those donor agencies, they will ask questions. The Federal Ministry of Health will ask you questions: where do you access those data from? So data must come from the right source, which is the Federal Ministry of Health. Okay, and so that is how this feedback mechanism flow. And also, interventions are being programmed from the Federal Ministry of Health and then to the state, to the local government, and then to each of those communities where they are mostly needed. And so for the structure of the integrated disease surveillance and response system, so it is very important for us to know that it is that surveillance is needed for a quick response to any particular infectious diseases. Okay, if there are no surveillance mechanisms that have been in place for any of those mechanisms, then we begin to see that diseases will begin to go out of bound, and diseases begin to spread within one population to another, just as Prof illustrated when we see one case, and the minimum that one case can produce is what? 2 cases, and from there begin to see a kind of geometric progression. All right, then the disease begin to spread within the community if sentinels are not being set up, if surveillance systems are not being set up to curb this disease at the initial stage. And that is why Nigeria, we are able to at least manage the spread of Ebola when it actually spread during, in 2014. So we are able to see, okay, what is the index case as it comes in, and then we are able to trace, into contact trace. And so that is one of the strengths of surveillance system. You can contact trace from the index case, how many individuals has this index case been able to contact with, and you begin to trace them to wherever that index case until you're able to curb that particular disease. And that is an important feature of a surveillance and response system. So for surveillance system, it can use surveillance activities from one disease to also strengthen other diseases. All right. So particularly if we see surveillance that is being put in place for various NTDs, for example, for soil transmitted helminthiasis and also for onchocerciasis. Anytime that surveillance is being done, you see that these two diseases go hand in hand. Anytime that mass drug administration is being carried out, it's being administered both for soil transmitted head-mediated that the albendazole that's been given out, and as well as the ivermectin that's also being given out for onco. Those go hand in hand. And so for surveillance activities, a surveillance activity for one disease can also strengthen a surveillance activity for this second disease. So those surveillance activities go hand in hand. So it's also built on synergy and also common resources. So the resources that you may want to spend for just one disease, if you are able to incorporate several or integrate several diseases to it, then you will see that you'll be able to cope the menace of several transmission within the community or within the locality that is being that surveillance system is being put in place. All right. So surveillance for one disease can actually synergize and also strengthen surveillance for the second disease. It also collects specific disease information. So whenever we go out for surveillance, as those in public health, it's actually specific for we actually want to check a specific disease outcome. It's not as if we are maybe in just unlike the routine information system where within the hospital the laboratory technician is there, the hospital management board is there, and whenever disease comes in, you have to do some diagnosis and then test and then be able to confirm before you start recording. But for surveillance system, we already know what you want to do, you go and do in the field. All right? And you already know what you want to assess in the field. And once you get into the field, that is the disease outcome you're actually looking for. That is what you are actually contact tracing. If it is Ebola, you are contact tracing, you are making a kind of contact trace for Ebola. If it's for COVID-19, you are making a kind of contact trace for COVID-19. So it is specific for a specific disease at any point in time. So that is one of the strengths of the surveillance system. And so it also relies on networks. So it has to do with a very good communication system. All right. If you want to contact trace in terms of surveillance, you must have a very good communication system. So you must be able to communicate where has this index case, where, in what places, in what location, who has this person interacted with. In which of these, the case of COVID-19, we see that the man from Italy came into Nigeria via the international air route in Lagos, and they begin to trace that person down to some of the southwestern states which the individual has gone to. All right. So it is very important to have a very strong communication system, a very strong communication network, so that one will be able to carry out surveillance in reliably in the country. So it's also, of course, some of the limitations of this integrated disease surveillance response is that it requires a very strong network. All right, and which, if one doesn't have that strong network, it becomes a limitation to a very good surveillance system. All right, are we together? If there is no strong communication, if there's no strong transportation system, it also falls back to the kind of routes we have, because you have to be very fast in terms of getting those the contacts which the index case has actually made through his travel or through his contact with individuals. So the network system must be very strong to actually be able to curb this disease or curb whatever spread that is being ongoing and nip it at the bud. It also requires an efficient communication system, which I've emphasized on, and also it must be timely, regular, and also require a very strong laboratory support. All right. So for those specific diseases, it is not just everywhere that a confirmatory test for those diseases is being carried out. So they have specific sentinels, and after this I will be looking at sentinels actually. It has specific sentinels where these diseases have been, where a confirmatory test can be carried out. So what we do in the integrated disease surveillance and response system is, one, of course, we can see cases, and also we can also get individuals, a kind of individual that are suspected cases as well. We treat them as cases at this stage. All right, because anyone that is being have maybe come in contact with an index case, you just treat that person as case at the initial time until a confirmatory test is being done, and you're able to reliably say, okay, this person is not infected, and this other person is infected, and you now begin to administer some intervention, whether it's quarantine we want to do or isolation we want to do. So that is what a surveillance, an integrated surveillance and response system does. And again, it must be quick. We require a quick feedback and also rapid response in terms of for we to get a very good success for this. And so the difference is also in case definition, which I have seen, so which I have said earlier. So the case definition here is both the both those that are suspected cases and as well as individuals that are confirmed cases as well. You treat them as this until you are able to reliably say through laboratory diagnosis that these individuals are negative for this particular disease or this particular disease outcome, or that individual is positive, and then you administer the right intervention. So for Sentinel surveillance, it has to do with specific locations where sentinels are being set up. And for this, we have to identify strong health facilities. So it's not all health facilities can accommodate or become a sentinel or to investigate a particular disease. So we have to identify strong health facilities that are actually equipped to actually manage some of this disease outcome. And particularly, for example, we have Ebola. When Ebola, then we begin to see places where sentinels was to be set up, and also in places where particular disease of interest, for example, also Lassa fever, to be set up, so that whenever we see suspected cases, we can actually refer them to those sites, and then the confirmatory test will be done. All right. So in various areas, we've seen sentinel. Also for entomological surveillance, there have been sentinel that have been set up for malaria as well, for entomological survey. For example, if for the mosquitoes that have been for example, in Nigeria, we have majorly 2 species of mosquitoes that actually transmit malaria. That is Anopheles gambiae, and also Anopheles gambiae. That is the complex, because it actually exists in complex. In Anopheles gambiae, we have about 7 complexes within that family. So they are efficient transmitters of mosquito. We also of malaria. We also have the other class of Anopheles funestus group 2, are also efficient transmitters of malaria. But majorly in Nigeria, we have the Anopheles gambiae, Anopheles funestus. But however, there have been reports of also Anopheles stevensi, that is also a much like an invasive species. Also is coming from now. They are coming from parts of India, and also coming into West African borders. And it has been reported in many countries in West Africa, like Ghana. Of course, a study too in Nigeria has also reported the presence of Anopheles stevensi, which can actually spread both the Plasmodium falciparum and also Plasmodium vivax. All right. So all of these are important features which we must note in the country whenever we want to set up sentinels. So sentinels for entomological surveillance too is also present in the country. So sentinel surveillance is necessary when the routine system is inadequate to monitor the outcome of interest, such as morbidity or mortality. It is often easier to get high quality data to monitor trends from sentinel surveillance rather than from the routine health information system, because it is easier to improve data collection and also collation in a small number of facilities rather than in the entire system. All right. So sentinels is always being put in place in designated facilities, health facilities, those that have the capacity to actually manage those kind of data. So sentinels are being set in place so that they can be able to collect this data, and these data are very quality data, because they're actually for specific purpose. That's why for specific reasons. That is why those sentinels are set up. And once they are set up, they are able to tackle that particular disease or fever or that particular health challenge of inference, and then be able to produce a very quality data, unlike the routine health information system that actually is a continuous something, and majorly because of motivation from the healthcare providers, and also some kind of challenges with the routine health system, that we may have some level of data that is not being that is not having a very high quality, and the rest of that. But for the sentinel surveillance, there is always a very high throughput in terms of data quality. And also sentinel surveillance is also helpful when disease outbreak needs to be rapidly identified, and that is one point we must note, that whenever a disease needs to be rapidly identified, we need a sentinel. We need sentinels to be set up in various areas or the various locations of the country. And so what will be the purpose of we setting up sentinels. One, for data, that data can be used to signal trends and also identify outbreaks. And that is one of the use of our time series analysis. Once we experience outbreaks of certain disease, the first thing we do is to actually go into a kind of analyzing them using our time series model to try and see, okay, what are the peaks and what are the months and what intervention can we actually put in place within those time frames to curb that disease from spreading further. And so it's actually give us the signal, give us a kind of an idea, a picture of what we can do at the present moment. And that is why time series model actually is very important in terms of identifying at the point of outbreak of disease. We also have to monitor the burden of disease in the community, and that is also one of the purpose of Sentinel being set up. And also, in terms of consideration for setting up those Sentinels, there are considerations we must put in place. One, we must put in place the location of sites, and it depends on the distribution of the disease. For example, when malaria vaccine was, the location where malaria vaccine was to be distributed was being investigated. So one of the considerations is, where do we have the high burden of malaria? And we'll be able to locate, okay, we have high burden of malaria in Kebbi State. And so Kebbi State was selected as one of those states where malaria vaccine will be distributed. So some of these ideas in terms of setting up sentinels is actually give us where intervention will be deployed the most, or where intervention is needed the most. So location is very important. So distribution of disease prevalence is very important in terms of setting up sentinels. We also have climatic variations. They are very important in considering areas where we can set up sentinels. Okay. Also, for example, for the case of Lassa fever, we also noticed that Ondo State and also Edo State are actually very high in terms of Lassa fever outbreak, and that is why sentinels were set up in those locations. So we also have, okay, what is the area of also intervention, or what intervention do we want to deploy to actually see? So for the climatic variation, I think Prof was speaking this morning on some climatic variations in terms of malaria and also in terms of SMC. So it's very important for us to know where to deploy intervention. For example, SMC is seasonal malaria chemo prevention, and they are being deployed in areas where the transmission of malaria is seasonal. So that is, the transmission of malaria occur within some certain months of the year, maybe from July, August, September, October, November. Within that 5 period, we see high rainfall, and then we see high outbreak of malaria, and that is why we advocate for seasonal malaria chemo prevention in those areas for children from less than of greater than 0 years to 5 years. And of course, like I said yesterday, there have been advocates to even increase this age band to school age children as well, to actually prevent the severe manifestation of malaria in them. So we also have capacity for the health facility. Very importantly, we must note that for us to establish any sentinel for any particular health facility, they must have the capacity to actually manage such particular health intervention. They must have the capacity. If not, of course, we are wasting our time. All right. So if they don't have the capacity to manage in terms of diagnosis, in terms of the technical manpower, in terms of the right equipment, laboratory equipment that is needed to actually investigate and also confirm these diseases, then we are wasting our time. So those health facilities must be able to have the adequate tools and the adequate manpower to investigate and also confirm these diseases. Again, for the sentinel surveillance, the number of sites depends on, of course, your funding. The number of sentinels you may want to set up depend on the funding you have. And so funding actually matters in everything we do. In public health, you must always do your cost effectiveness to see, okay, which area actually needed the most to implement those sentinel sites. So funding is very important. Population density is very important in those areas. How many population is actually being at the risk group in those particular areas? Do we have, should we implement this sentinel in this area? Also, all of those considerations are what you must. We also must also look at the severity of the disease we are looking at. Is it a contagious disease? Is it a disease that spreads sporadically? All of those considerations are the consideration must take in place in terms of setting up sentinels. So particularly some of the strengths of sentinels is that it's complete and also more reliable data in terms of morbidity and also mortality. So they are majorly data that can actually show some causal effect. They can actually tell us, unlike the routine health information system, where we may not be able to attach a kind of causal effect to them. But for the sentinel data, we can actually attach, okay, this particular disease of outcome is due to this particular infection. All right, so we can actually attach a causal effect in terms of for the sentinel surveillance, and we can actually say, okay, this death is actually as a result of COVID-19. This morbidity we are experiencing is actually as a result of LF, lymphatic filariasis. We can actually attach the causal effect of those. So can detect also outbreak, provide specific data for entomology. Just as I mentioned yesterday, for the PMI, the US Presidential Malaria report that's actually been done. Of course, some of the US policies now has actually affected most of these data sources because of the new US policies. But before now, we have data Sentinel that actually report for PMI report for entomology within the country, and also parasitological data talk about for the Sentinel being set up for TS study, therapeutic efficacy studies for ACTs. So Sentinels also be set up for that to see how effective is our ACT being used, how effective has it been, what is the efficacy of ACT in the country. So several Sentinels is being set up, about 14 Sentinels actually for TES study for it's also for pharmacology to test for our drugs, how effective they are, and the rest of that. So can also cover several topics. The Sentinel can also be used, just as we saw earlier, can also cover several topics in terms of disease outbreak. So can also provide information for all stages of the program. So the inputs we get from Sentinel can provide information from the basic level, from the community to the local government, to the state, and then to the federal level. So some of the limitations of this, of course, whatever have its own advantage, also have its own drawback. So they are costly to set up actually, because it will require equipment, it will require manpower, it will require so many even motivation too, also on the part of some of the healthcare providers. So it requires all of these things to be able to manage a Sentinel center. So it also requires frequent supervision from the Federal Ministry of Health. They always have to send individuals to those Sentinels to actually see how those Sentinels are performing at each site. All right. So sites not representative of all the health facilities, unlike the routine health information system, which is virtually from the community, or every of the community are reporting. But for Sentinels, it's actually specific designated centers that actually confer the responsibility to report those cases. And then, of course, changes in use of health services can introduce bias in trend and data as well. And also, not always sustainable. It's not always sustainable. We have, of course, seen them in some of the Sentinels already, that if fund is not being provided for those specific Sentinels, then every of the activities just will be halted. So it's required consistent funding, because most of the Sentinels, unlike the routine health system, where at the beginning of the year, a kind of budget has been done for that already, and it continues. The Sentinel has required funding from donor agencies and some other, from the Federal Ministry of Health, also to put in some funding to that. So if there are no funding, then the Sentinel will be the activities of the Sentinel will be affected. So it's also easily expressing stock out in terms of if we are carrying out a kind of Sentinel for pharmacological study, if there is stock out of the drugs to test, then the Sentinel activity will halt. So it has its own drawback. So it actually hinge on consistent funding for the Sentinel. So once there is consistent funding, the activities of the Sentinels will continue unhindered. But once we don't have funding, that will actually be affected. So we have some of the differences highlighted here for the routine health information system, also for the integrated disease surveillance response, also for the Sentinel. So for the coverage for the routine health, We have it's actually for all of the facilities, but for the integrated disease, not all the facilities, but for the also for the Sentinel, we just have few facilities that are reporting. And also for the frequency of reporting, we have monthly and also quarterly. And it's very also important that for us to note, I think Prof responded to that yesterday, that particularly for any mathematical model, we require to do a good mathematical model, we require either weekly data or some sort of monthly data. And that will actually give us the pattern. It's just like I was just with one of my group members in the work yesterday, and what they did was just a kind of cumulative study, accumulating the monthly malaria cases, and what you just see is just a kind of a straight line. And that will not really give us the picture of malaria at the end of the day, because what we want to see that seasonality. We want to see where the malaria is peaking, and want to see at what point in the month can we actually implement some certain intervention. And so it is very important for us to, when modeling, I think monthly and also weekly and also monthly data is very important. And this is what these data sources actually provide. So also case definition, like I've made mention, for the integrated disease surveillance, both the suspected cases and also the confirmed cases are actually treated as cases until a major confirmatory test is being done. So I'll be ending with this session, which is survey. Survey can actually come through, it can be a personal study, all right? I will run through this because majorly in our discussion yesterday, we've touched on some aspects of survey, which has to do with DHS, also the MIS, and also the mix, all right? And some questions we actually raised through from each of these, and which we responded to. So survey, particularly, they observe a standard protocol. All right, there's a standard protocol for survey, and once the investigators go out for this survey, they actually stick on those protocols, collect data based on the protocol, and then bring back feedback. And particularly for survey, in the country, we have major surveys, not just personal survey. Of course, individual researchers can carry out survey through questionnaire, developing the protocol for it, and then going to the field and then collect some data. And the data that have been collected majorly are cross-sectional data, 1 point data. All right, is that okay? So, but we also have situations where data is being collected intermittently, and that actually goes not just beyond the cross-sectional, but also a kind of a longitudinal something. So survey when done in a more large scale can also be longitudinal, that from time to time or intermittently data is being collected. And take for instance with the DHS data, it comes every 5 years, and we have MIS within, and with that you can actually collect each of those data and then make some kind of inference between each of those years. And that is why you can actually talk about malaria prevalence in 2010, malaria prevalence in 2013, and those are DHS MIS years, malaria prevalence in 2015, malaria prevalence in 2019, and also for the last MIS data that has been collected, malaria prevalence in 2021. For us, it is very important for us to note, just as I've made mention earlier, funding is still very key, because now the from the NMEP, they are still being short to around, okay, because for MIS, it is very due to actually conduct an MIS in the country. But because of lack of funds, previously now it has been the US fund and the rest of that is being used for the conduct of some of those studies. But presently now, as we speak, there are lack in terms of funding, and that is why it's been advocated we must own our own thing, all right? As a country, as a state, we must own it. So we are now advocating for country ownership of each of those programs, so that we're able to implement as when it is due, all right? Not just depending on the donor agencies or fund to actually come to our rescue at any time we want to carry out any perhaps disease surveillance or any survey at all, to actually bring to bear our own health challenges in the country. So it must be country owned, it must be state owned, it must be local government owned. So we must try as much as possible, even within our own local context, to actually solve our own problem. And that is one of the hinges that's actually preventing the current MIS report. It's the issue of funding. So the purpose for survey are So the purpose of survey is actually to also get information across the country. So survey is always being, of course, you have your sample, all right? You have the sample size you want to investigate. So you're not going into the country, you are not going to the state or into the community to start sampling everybody at random. Of course, you have limited resources, you don't have the capacity to do that. So you have a statistical approach to it to get a representative sample for the survey, and then with that, we'll now be able to generalize for the entire population. And it's very important because survey will actually give us a kind of a snapshot of what is happening with that sample size, a snapshot of what is actually happening, whether in the entire community, in the entire state, or in the entire country. Please, this slide. All right, so for the survey type, of course, it can be at the national or population level. All right, so it's also mostly cross-sectional because it is at one point. All right, it's at one point. Most of those, except those that intermittently is being collected from year to year, which we can also carry out, which we can actually use to measure, and which we will see that in terms of the importance of conducting survey. It's also repeated, so repeated surveys of the same target population. So surveys are also repeated if it's, for example, the DHS survey and also the MIS survey and also the mix. All right, these are examples of survey which intermittently are being repeated for the DHS every 5 years, and also MIS within the DHS years. This slide, please, as I draw the talk to conclusion. All right, so maybe we just continue with the talk before the slide comes up again. So particularly we've emphasized on the need for survey, and I've emphasized that for survey we always would need a representative sample to carry out the survey. And particularly for us to carry out that survey, there must be some statistical background for us to see the sample size that we need. So we can use several formula for that, like the Cochrane formula and the rest of that, to actually see, okay, what kind of sample size that is representative for that community. And once that we're able to get our sample size and we carry out the survey within that population of that sample, then we can actually then infer for all of the entire population that, okay, this is what is being obtained in the country. So for the strength of survey is that it assesses quality of care. So quality of care for the country can actually be assessed through the use of survey because it is representative. All right, we are talking about something that cuts across, unlike the routine health information system that actually focuses on individuals who are visiting the healthcare. So, but for survey, since it's a community base, it's representative, and it's also we can use it for prevalence. You can see that this is the prevalence of this certain disease because at the end of the day, it cuts across. It does not, unlike the routine health, where you have some sort of population who are asymptomatic to the disease. Okay, those populations are not captured. But for survey, it actually captures both the symptomatic and asymptomatic because we are going to the population. And once we are administering tests, whether through RDT, how has it affected? How is individual using the LLIN? What is the coverage level? Those taking ACTs, are they actually complying with the treatment regimen, or are they just maybe once they take the drug and they feel all right, they keep the rest of the drug? So all of these are information. Once our survey concerned with programs, with national programs, then it can actually also help answer some national programs questions in the program. So detailed information that is typically available also in the routine system, available in survey. So if you look at the DHS survey in their protocol, you will see a whole lot of health information It's just that it's just quite unfortunate that at present, one, we may not be able to register for that DHS. But before now, you can actually go to DHS platform and put in your details and register, and you get access to those data. But for now, due to state the policies again, there's been a kind of halt. Except if you have access before now, you can still access that. So of course, survey is very important in terms of operational research. So it's not just a kind of research that we do just to put it at the shelf. It's very good for operational research, because once it coincides with the program that is ongoing in the country, then we'll be able to assign them to particular health coverage or health usage or intervention being put in place, and then we'll be able to say that, okay, that this program or this intervention that has been put in place has been able to cover the maximum number of people that we want it to cover. Talk about the SMC. Then we'll talk about, okay, if we're able to carry out surveys on the distribution of SMC within those states that is being covered for SMC program, we're able to say, okay, that for this particular intervention, that it actually reached the population that needs them in question. And so those are some of the highlights and also some of the advantages of survey, and also over other kind of disease data collection. And also other disease data collection also have their own advantages also over. So before routine health system, it's a continuous process, and it covers all of the months of the year, unlike also the survey. But the survey is more of cross-sectional and also can be generalized in the entire population, which we can talk about prevalence of the disease. We can talk about how the programs or interventions have been implemented over the years, how it has helped to bring down the incidence or the prevalence of that particular disease. And so when you maybe plot or take a kind of map of the incidence of malaria over the years, you begin to see, okay, what are the effects of some of these interventions that have been put in place over the years to the prevalence of disease. So I would love to end my talk here, and thank you very much for your rapt attention and for listening.